haptics are already broken, but he's in the AC with the other haptic inside. But he's not yet confident with the IOL cutting within the AC and also with the proper vitrectomy. So how to prevent and how to manage at a beginner level?
First, if you have backup, better such cases seniors handle. But if you are alone and you have stuck up with this situation, probably I would, if the, as you are saying, it's halfway through, probably the IOL is in the anterior chamber. If it's possible, I'll first inject a viscoelastic from side port so that the chamber becomes stable first, and then once the haptic is cut, maybe it will be halfway through. I mean, some part of the optic has gone inside, the IOL has gone inside, some gets stuck into the injector. Release it, then make the chamber well, coat your endothelium also if possible, protect the endothelium, protect the PC, and then if it's a very beginner, probably he can extend the incision, take out the IOL, then load another new one, implant it, and if required, suture the incision, because once we extend, it will be a leaky wound probably. Or make an make an SSS incision, scleral incision elsewhere, take out the IOL and then put again. Or if it is a very skilled surgeon, can do the cutting of the IOL, but it is little bit tricky, I suppose, to cut the IOL inside the anterior chamber.
Yes. So one last question to Dr. Varghese sir. So this is a junior surgeon who is still practicing, but he has got a soft cataract. So he has actually tried chopping, and during this, what happened is he's created a central bowl-like thing, and he doesn't know how to go about next. What should be done?
What I will do is I will do a hydrodissection again and bring the nucleus into the anterior chamber and emulsify. That is the best thing to do. You can hydrodissect again, just use a hook to bring it to the anterior chamber and do your emulsification.
Dr. Amita ma'am, so they have become a little more confident, they are okay with the normal cataract surgeries, and they have started doing premium IOLs also. But they want to upgrade themselves to toric IOLs. So what tips you would like to give? When to start and how to practice before going to the OT?
Well, they can practice. One way is that you can start marking the patient, even though the patients don't need a toric. For those patients also, we should start practicing how to mark the 180-degree and the 90-degree mark. And once you feel confident about that, then maybe you can start, when you do, even if you're doing it on an automated system, you do the manual method of marking and keep the manual marker on the, when you're doing it on the table, operative time to correct the axis marking and all that. You start doing it, and you can do it under supervision first, few cases with the senior with you, and then you can, then it becomes easy. It's not difficult. The marking should be learned properly, basically. Yes. 180 and 90-degree, that marking.
Any other questions from the panelists for the junior surgeons? Anup sir is there. Any comments, sir?
Regarding you said, no, when you have done your fellowship and after that you have a lot of problems, back-to-back problems. The thing is, fellowship doesn't mean that you have become top of the, you're not the boss in that field. It is just an introduction to that area. Suppose you have done a cornea fellowship or a phaco fellowship, and it depends on which place you have done, how many surgeries you have done, because in some places you hardly get any surgeries, some places you may get huge number of surgeries. After that also you have to work, you have the license to work in that area, and then you have to do a lot of surgeries before you become, you can truly say that you are confident and you are a boss in that area. So till that time, you should not have an ego that I have done a fellowship, I am the boss in glaucoma. No, there is still, you take lots of years for you to really reach to that level. But the thing is, many people after that, they just go plateau actually. That is the problem what happens. After fellowship, they will do few cases and they will keep on doing the same things. Like say a glaucoma, they will just keep doing the trap and they don't want to go to the next step like doing MIGS. Or there are so many things which are coming out. So you have to have that mentality to keep on progressing. Then only I think over a period of time you will reach the top. Complications everybody will have, but this is what is my opinion on that. Thank you.
So, is there any cutoff numbers after being a junior surgeon when you should actually start?
Actually, numbers don't matter. Just like Dr. Anu said, numbers don't matter. You have to keep on and on.
So, I think any other questions from the audience? Any questions to the panelist? Any doubts that you have as a junior surgeon? So I think we have come to the end of this session. We had a fruitful discussion also. Thank you everyone. So let's just have a group photo.
Let's start with our next session. The next session is secondary IOLs. Now that we have started doing phaco, we have started with the phaco in the last session. Anyways, we have to deal with complications. We have to come out of the complications. We anyway will have to be having hands-on with any kind of secondary IOL. At least one you should know. Then only you will have a way out. So let's learn secondary IOLs, the different kinds of secondary IOLs, what practical tips that we can have. We'll start with the session. I am Dr. Lakshmi. I am from Giridhara Institute, Kochi. I'll just start with the introduction, indications, planning of secondary IOLs. So secondary intraocular lens implantation, indications, planning. I'll be also talking about AC IOLs. So what is secondary IOL implantation? Implantation of an intraocular lens following an initial surgery that resulted in aphakia or a deficient intraocular lens. What can be the indications of secondary IOL? IOL exchange, as in incorrect IOL power, IOL subluxation, opacification of IOL, photopsias, dissatisfied patient with multifocal IOLs, IOL-induced inflammatory response and cystoid macular edema, IOL-induced endothelial decondensation, IOL removal, and later secondary implantation in chronic endophthalmitis. After congenital cataract surgery in children less than 1 year, after complicated cataract surgeries, the most common, trauma, uveitis, and after refractive surprise. Patient selection is one of the main things in secondary IOL. History, very important, because you have to sit with the patient and take a detailed history as on the timing of the previous surgery, the type of surgery, the trauma in detail, what kind of trauma it was, like what investigations is already done. If you have an EMR access to the already, or the case record access to the already done surgery, it is well and good. Refraction definitely needed, because you need to know how much vision the patient can get after the secondary IOL implantation. So a detailed anterior segment examination, including the conjunctival status, including the presence of glaucoma, drainage devices, because when we are planning the surgery, there are many options of a secondary IOL. So which option to choose depends on the examination of the patient. Cornea, clarity, edema have to be noted. Pachymetry, yes, should be done. Specular, definitely, if to assess the endothelial cell count, especially when you are doing a AC IOL. And yes, chamber depth, vitreous prolapse in AC, you have to note. Even a white to white diameter also can be done. Iris and the capsule status. See the patient undilated before dilating the patient, because if you're planning an iris claw lens, you need to know the pattern of the iris, how the pupil is before, and whether there are thin areas in the iris before doing that. Always see for the incisions in the primary surgery, like whether an SICS was done, whether any retina procedure was done, whether there is a buckle, you have to see before. That means examination is really important before you proceed with or you plan the secondary IOL implantation. If an IOL is present, the degree of subluxation and the type of IOL, because when you're planning a secondary IOL, can the primary IOL be reused? That should be kept in mind. So the type of IOL should always be looked forward. The timing of the prior surgery, whether the SICS wound would have healed 5-6 years back, the SICS was done, whether we can open the same wound or should we make another wound, all depends on your examination or the anterior segment examination of the patient. Posterior segment examination is valuable in case that some conditions limit post-operative results. That means we'll have to definitely keep in mind whether the patient will improve after doing a secondary surgery, whether we are going to incite inflammation, whether the retina is good or bad, because after doing the surgery, the patient should get some vision. If the patient is not going to get vision, should we definitely take the patient for the surgery? That should be kept in mind. And one advice is always, if there is a subluxated cataract or if there is a subluxated lens, make the patient lie down and see how the lens dangles, like if it is in the mid-vitreous, because when we sit, if there is a superior attachment of the lens, we cannot see that. But when the patient lies down for the surgery, then you'll have to definitely have a retina backup. So the retina backup, we should already tell to the retina persons, otherwise they won't come for the retina thing. So keep in mind, make the patient lie down and see the patient, see where the lens is. So that is regarding the patient selection and the criteria before considering which type of lens or which type of secondary IOL that should be, that the patient should undergo. So the options are a single piece or a 3-piece foldable IOL in the back, or a 3-piece implantation in the sulcus. AC IOL, iris fixated, can be anterior or retropupillary, and